As we let people in from the waiting room, we'll run through our agenda today. We have a pretty packed agenda, so we don't want to wait too long to get started here. I'm so glad to see some new faces on our call today. If you haven't been on our eConsult work group call in the past, we meet on a monthly basis to discuss best practices in eConsult policy, reimbursement, and workflow. So my name is Libby Sagara. I'm with Blue Path Health, and I'm glad to meet you all. If you haven't been on our call, please feel to introduce yourself using the chat. As we go through our presentations today, we'll have you all on mute as we present, and at the end of our presentation, we'll open up to some conversation to hear from you. If you were able to join our annual meeting back in November, you may have heard some of these materials. We'll be sharing some of our findings from our annual meeting survey. We'll talk a little bit about our accomplishments from 2021 and what we want to look to be focusing on in 2022. So please do share your input. We are really interested in hearing through the chat, or if you'd like to remove yourself from mute in our discussion time to make this as interactive as possible with the large group. I'm going to wait just a moment for my guest speaker to come on. His name is Tamir Malik from Geisinger Health. It's great to have an example from the East Coast. We try to bring in national examples of eConsult best practices. Many of our practices out in California who have gotten up and running on eConsult are in rural settings. We want to be able to talk about eConsult in both rural and urban, of course, but this example is a great example of how we can see rural neurology needs being met. So Dr. Malik is going to talk a little bit about that. And then when we wrap up our call today, we'll get back to moving from not just workflow, but more into a policy focus of what we want to be able to tackle in terms of ongoing issues around eConsult. I'm going to skip ahead a little bit since Dr. Malik isn't on with us quite yet to our summary of our eConsult work group. And when we get back, we will, when we get back to Dr. Malik, we will get to his presentation. So moving on to this slide here. So those of you who've been joining us over our past few years, we've actually been around for 6 years now. It's so exciting to see our growth and our accomplishments over the years. We have seen across California, across the country, both support from managed care plans from payers across the country, and in addition, commercial plans getting engaged to support eConsult programs. As we know, payer support is so important to get our providers up and running on eConsult. As Medi-Cal managed care and other managed care programs have supported eConsult, we've shown support and seen support grow for uninsured patients too, which has been great to see. Over the past year, we've seen a good number of eConsult for CME start up. So we've been able to offer continuing medical education for providers to spur some interest in eConsult. We know that this is an extra step for providers, and we want to be able to acknowledge that too. For those of you who are out in California, we stood up State Bill 365 to support eConsult for primary care. We got all the way to the very last bit of hurdles, got through those hurdles, and unfortunately our bill was vetoed, but we want to be able to go back and present that once again in 2022. So we're pleased that we have support from across the state, and we'll share those examples across the country for those who are interested in similar legislation. One thing that we've heard loud and clear is we want to hear patient examples. So patient stories of how eConsult is effective, and patient voices. So as part of doing that, we want to have better tools and examples of how to talk to patients about eConsult. So that has been one of our focus areas this year, and we'll continue to be focusing on in the next year too. Some of what we've heard from you all in terms of what we can do in 2022 to make eConsult more accessible to all is to encourage reporting. We've seen a lot of payers get together. We have some great examples of how payers are collaborating to encourage eConsult provider adoption. So by sharing some of these examples through dashboards, et cetera, we'll share an example later today. We want to see greater involvement in that way. And we've heard some different examples of how e-consult incentives have been put into play. We'll talk more about those strategies for providers in the coming year. This year, of course, has been such a challenge for all, not just with regard to COVID, but as you've experienced all across the country, our environmental challenges that we've been facing, disaster preparedness, fires out on the West Coast, behavioral and mental health impacts of the pandemic have all been challenges that we have gotten some great examples of how we can address through eConsult. Another message we've heard loud and clear is that eConsult programs work much better if they're supported across business lines. So we know we've focused a lot on Medicaid eConsults, so we want to be able to provide examples of where this is happening in commercial settings too. And last, be able to address some of these disparities that we're seeing. Some of our great programs out in California have been focused on the needs of those patients who cannot get access to care. So want to continue to offer eConsult examples of how to address health disparities. We'll talk a little bit about that more after we have our featured presenter. So Dr. Malik, I see that you're on today. Dr. Malik, if you would mind sharing, you could show your screen. That would be great to see your face, and I'll be happy to introduce you. I'm so glad to have you on today. Dr. Malik is with Geisinger Health, and he's going to speak to an example of how eConsult is being done in a rural neurology setting. So Dr. Malik, as I'm sharing your slides, if you wouldn't mind doing a quick introduction of yourself, and I will get your slides up and running. Thanks for joining us today.
Sure, absolutely. Good afternoon, everyone. It's evening in East Coast. I know that a lot of people are from the West Coast, so there's a lot of time difference. I'm one of the MS neurologists at Geisinger, and I have been part of the healthcare system at Geisinger for the last 7 years. And we have seen that the access to neurology was always an issue. And we wanted to use an online interface that would help to relay the primary care physician concerns to the neurologist in time, and then ask them any specific question about the patients if they had any. So we looked at the 5-year data that we have, and I'm happy that I can explain a little bit. So next slide, please. So Geisinger Health System is a multi-specialty practice. We have about 8 hospitals in the central Pennsylvania. We also have a lot of Geisinger physician offices where we get the referrals, but the 2 main hospital centers are the GMC, which is in Danville, and the GWE, which is in the Northeast. But we have neurologists, about 45 neurologists across the system. But we always had that concern that we are not seeing the patients well in time. Whenever the primary care physician would whenever he would send a referral to neurology, the 10-day time to be seen was always very high. Sometimes it would take months before the patients would see a neurologist and get their concerns. So we wanted to implement some kind of a system that there is a communication, because if you are in your electronic medical record, sometimes even if you get a staff message, you will not get to that. But when you get an Ask a Doc, which is the one that we wanted to implement, there is a red flag that makes sure that you are able to read that message and get back to the person who is asking about that question. So a little bit about the deficiency of neurologists across the US. If you can go to the next slide, please. As I was mentioning, that with the increased Geisinger health system, the demand of neurology was exceeded the present clinical capacity. And if you see in this publication that was published in 2019, they projected that the shortage of neurologists would get worse with the passage of time. Even in some states, which were pink in 2012, they will get red in 2025, because the supply is much shorter as compared to what we are actually getting out of the residency programs. And it's especially worse, like if you look at the Pennsylvania state, which is going to actually get slightly worse as projected in this publication. So if you look at the consultative care delivery, next slide, please. So the specialty consults that are never needed can result in overutilization and unnecessary expense. One more thing I forgot to mention about the Geisinger health system is that we do have our own insurance. So the people in the area have Geisinger health insurance, and we have these hospitals in which the patients are seen. So if the consultation is never needed, we are actually causing unnecessary expense to the system, and we are overutilizing our neurologist. That could lead to delay in the care, because if there are patients who need to be seen sooner, they will be pushed back because there are other people who will be in line that have got the referrals from their primary care physician. So both of these things can lead to potential harm and patient anxiety, and actually can burden the specialty access, which can delay care and can be very detrimental in patient care. So what was the solution? Our solution was a screening tool that avoids the unnecessary consultation, makes sure that the patient who needs to be seen urgently are seen sooner. And by doing so, we are allowing to order some preliminary tests before the visit. For example, if there's an MS patient who is going to come to the clinic, we want to make sure that they have updated imaging so that we can discuss about potential treatment strategies. But if they come in without any imaging, or we don't know what their imaging status is, we might have to ask them to come back again. So that would delay care, sometimes even for months. So we came up with this idea of Ask a Doc. It's a program which is built in our Epic. It's part of both the outpatient and inpatient EMR. So whenever the primary care physician or a specialist who is asking another specialist about a specific question, for example, if I am an MS specialist, I'm asking a hematologist about lab abnormalities in a patient who is on a disease-modifying therapy, which is not a side effect of that medication. I want to make sure that I'm not over-treating that patient, or if I'm missing something, I need to make sure that that condition is addressed. So we developed this communication, and it's very easy. If you go to the next slide, please. So what happens is that the provider or the specialist asks a question. It takes them to a Microsoft Edge page in which the patient information is already added in. And the physician asks a question based on the complexity. And if they have any other question, for example, a side effect of a medication, so they will complete that document, and they will route the Ask a Doc to whoever is on call. But sometimes you can also send that encounter to a specific specialist. For example, we have an MS specialist who is seeing patients, but the patient was lost to follow-up. So the primary care physician would address that specific question to that physician. And once the specialist would get that Ask a Doc in their in-basket, they will review the chart, and they will write their answer and send it back to the primary care physician or the other specialist. So that way, it's followed up in the EMR, so that they are not missing these Ask a Docs, and the primary care physician is getting the answer to their question. So next slide, please. So the care delivery model with the Ask a Doc You can even do a phone call even, and then you can also do electronic messages, as I mentioned in the process. So this way, it helped us to make sure that the patient who are to be seen earlier are seen early, but it's not by an accident. They should be seen because their condition is concerning, and they also decrease the amount of stress and burden to our health organization. Next slide, please. So this delivery model, Ask a Doc, was already well established in some of the other departments. There are about 12 departments that are taking part in Ask a Doc. And in these departments, when we looked at the quality, it actually increased the access by 33 days. And it also decreased the cost of the clinic visits by at least 10,000 per 100 consults. It also improved the revenue because these patients that were seen earlier, and it also can help because our healthcare system is providing the patient, they are providing the provider with the RVU if they complete one Ask a Doc in the right way. So you get one RVU for each completed Ask a Doc. So it doesn't take out the time, so you're not affecting your productivity.
Dr. Malik,
yes,
can I interrupt? Because I think we spend a lot of time on these topics here, which are so important for us to understand, so we can try to measure these consistently. We do this in many states across the country, and would love to be able to know, maybe you can help us with this a little bit. In terms of 30-day reduction, in terms of wait time, what were your wait times before in terms of wait time for a visit? Was it like a 6-month wait, or what were you looking at?
So initially, the wait times for the clinics was at least even in months. For example, for seizure patients, patients would have to wait at least 3 to 4 months before they could be seen in the clinic. And we actually measured that the percentage of patients increased with the passage of time. As soon as a primary care physician would place a referral to neurology, the time to be seen increased from 38% to close to 60%. So it definitely increased the access to these patients because we were filtering out patients who didn't want to be seen. But it was dependent upon each specialty. For example, if it was an urgent stroke patient, definitely they would go to the ER, but this was more outpatient based. So it would also depend upon how many specialists we had. And we looked at different subspecialties as well, as I will talk more about in the further studies, in the further slides.
Thanks. Just one more question. In terms of reduction in payer expense, does that count travel, or how do you know sort of what goes into that calculation of cost of care?
In terms of the reduction in payer clinic visit is that we are trying to limit the unnecessary consultation. So indirectly, it would be a measure of savings for the healthcare system because we are not seeing patients who are not needed to be seen.
Thank you. Great.
Sure, absolutely. So there were about 45 neurologists that were part of the study. We did about 5 years, close to about 5 years of study. We looked at the number of Ask a Docs over the course of these years. We also looked at the accurate completion, any workflow limitation, and the average turnaround time. We also looked at how much 10-day referral was increased over time. So our results were very encouraging. If you go to the next slide, we did see an increase it's like a steady increase from Q4 2015 all the way to Q4 of 2019. They increased close to 250 messages for each quarter. And that can also help to increase the RVU production of it also increased the production of the department as well by increasing the RVU productivity as well. In terms of the results, we found, if you go to the next slide, please. So about 1% of the Ask a Docs were completed within an hour because they were urgent. Most of them were completed within 3 days. I would say 90% were completed within 3 days. And then when they asked us questions which were not urgent, they were less than 0.5%. So in total, we saw around 3,000 Ask a Docs over the course of these years. And there were some limitations. Some of the times it was a routing problem. Sometimes our Epic would give us the primary care physician as a routing provider. Sometimes the time limit was not consistent. The neurologist would take more time to reply to these questions. And sometimes they would not use the accurate smart phrase, which is we have built in our system so that the provider would go through each questions and make sure that they are routed to the correct primary care physician or another subspecialty provider. In terms of the, if you go to the next slide, please. So in terms of the specific providers for Ask a Doc, most of these messages were for general neurology, but again, there were neurophys physicians that these messages were going to. We also have a very interesting model. So at Geisinger, we have a 24/7 neurohospitalist. And during the daytime, we have two services, the stroke team and the general team. After 5 p.m., the general neurology and the stroke physician go home, and then there's a nocturnist who comes on. So every time there's a neurologist on call. And in case if it's an urgent message within an hour, the neurologist on call would give recommendations to the primary care physician and make certain recommendations as where the patient needs to go. In terms of the primary care physician, next slide, please. So in terms of the patient satisfaction, there were a few dips across the time when the primary care physicians were not happy with the care, but we improved it over time. And by the last quarter, it was close to 4.9, which speaks for that we were making sure that the questions are answered in a timely manner so that the primary care physicians and the patients are not anxious. And it might be the fact that the neurologist also grew comfortable with the process. In terms of the access, the next slide, please. In terms of the access, as you can see that we were able to save a number of different spots over time. And we were able to at least save consults by just answering these simple questions. Sometimes it's as simple as how if the scan, for example, if a patient presents with headache and they are getting an MRI of the brain and it shows white matter lesions, and the radiologist writes that we are concerned about MS, small vessel disease, stroke. So it can be like if a neurologist has been very well read in the neuroradiology, they can easily answer that question whether those lesions are small vessel versus whether they are actual demyelinating lesions. So that way, we were able to prevent unnecessary referrals to neurology over time. And as you can see that from 30 all the way up to 450 spots were saved over the course of 5 years. And you can see that there's a steady incline towards saving these spots. I'm sorry, did anyone ask me a question?
Yeah, there's a couple questions, Dr. Malik. So the first one, I think you covered, but just want to clarify. So how do you define specialty access, the 33-day reduction in wait time? Does that mean that those patients that got any consult waited less for a face-to-face visit, or is it overall that the wait time for neurology reduced by 33 days? What does that mean exactly?
I think it's an excellent question. So that was the reduction overall in the, so we looked at the 10-day referral decrease in time. So that actually decreased from 60 to 33 days. So it decreased over time. So it was the whole department as such that we were able to decrease the wait time for the whole specialty.
That's very helpful. And then I actually had a question for you around PCP satisfaction. You noticed that there was a little bit of a dip and that your program did focus on primary care satisfaction. You said initially, I think you mentioned that part of the reason for satisfaction dipping might have been the response time. Was there any sort of coaching that you did to encourage quicker response or more clear responses? Or what kind of coaching did you provide to your specialists to increase the primary care satisfaction?
Yeah, that's an excellent question. So I agree that the PCP satisfaction was more related with the turnaround time initially, and then as the process was made more simpler, the neurologists grew comfortable as they were doing more of these Ask a Docs. So that helped to help the patient. The PCP satisfaction was increased based on how quickly the responses were sent back to them and how accurately the question was answered. So I feel that helped in both ways, both in the neurologist getting more trained with the process, and the turnaround time was getting smaller as well.
Thank you.
Sure, absolutely.
We just got a comment that they love the slide number 18, that it's great to be able to measure spots saved. And we try to explain this often to our state regulators, to those who are in charge of payment, noting that if you only have a certain number of spots, how do you make sure that it's clear that you're not creating more spots? So you have to be able to save those spots for those that are actually needed, right?
Yes, absolutely. So
I just went to the wrong slide. Sorry about that. Getting back to your slides.
No, that's okay.
So any other questions coming in for Dr. Malik? I think this slide 18 is super effective, and it would be great to hear if other organizations are able to measure these kinds of data. Go ahead, Dr. Malik.
So this was the time to be seen once the referral was placed. So you can see that initially when we got the 10-day referral, the percentage of patients that were seen within the 10 days was very low. So only about 38% of the patients were able to be seen within 10 days. But as the process grew, it dipped a little bit, but then around 2019, we had a steady incline, and it goes up till 60%. So it's a huge jump if you look over time. So that was remarkable, that how we turned around the time to be seen once the neurology referral was placed. It's great to see that the patients who were able to be seen earlier were seen earlier. We also did, next slide, please. We also did a small analysis. We looked at about 70 Ask a Docs, and we saw that it was able to defer consultation in about 41% of the patient, meaning that patients who were needing certain important testing before they can see a neurologist. For example, if a meningioma patient didn't have any recent imaging, we wanted to make sure that they get the appropriate testing before we see them. It's not that we were refusing care, we just wanted to make sure that they got the appropriate testing before they were seen in the clinic. And 37% of the Ask a Docs in that cohort, we were able to avoid the consultation altogether meaning that we were able to save not only the healthcare system, but also save both the neurologist time, the patient's time, because it was a very simple question, like maybe I can give you examples about migraine. Patient is having migraine, what medication do you need to start them? And it's a typical migraine, no red flags for headache. So you just start them on a medication, and then once the access increases, and if the headaches are not getting any better, definitely the patient needs to be seen sooner.
Dr. Malik, this is so important. These data points, I love these because we've been talking about this for years. And Dr. D, who's from Los Angeles, I know you're on, and I think we're stealing this from your program, that you want to have the right care at the right time. So this point on deferred consultations is so important, that the patient come in at the appropriate time with the appropriate tests, with the diagnoses, or sorry, the diagnostics in place, so that you don't have to have a repeat visit or redundant testing. Thank you so much for these points.
Yep, definitely, it's very important. So in conclusion, next slide, please. So in conclusion, we feel that there's a national shortage of neurologists, which is going to get worse. And it's very important to limit the burnout, especially in this COVID era. A lot of people are getting burnt out. The same goes with like the telemedicine has flied off, and it has been having significant benefit with the e-consult in place, and especially in our rural neurology setting, patients have to travel for many hours, at least 2 to 3 hours on average, just to come and see us. But this way of communication can definitely improve the access. It can improve the patient satisfaction and the primary care physician satisfaction as well. Our study did show that it was reliable, it was timely, and it definitely adds value in trying to make the e-consults a universal thing. And as you said, it's the right person, right care at the right time. In terms of the future care, we do want to look at the next slide, please. At the cost effectiveness, the quality of patient care, and the time and work efficiency of the neurologists, downstream revenue, and again, looking at the patient and PCP satisfaction as well. I can take any questions if there are any. Thank you.
Wonderful. I encourage questions to come in for Dr. Malik. I had a couple questions myself, Dr. Malik, and one of those around just looking at cost effectiveness. You noted that Geisinger has its own plan, so your patients are insured by the organization, and so it's obviously a great cost savings to you to be able to treat these patients most effectively. Is Geisinger able to accept patients from outside of the system? Do you have referrals coming in from, community health centers, or those that have, say, Medicaid or Medicare coming in from the outside?
Yes, that's a great question. So we do see a lot of other health insurances as well. So we take all of the health insurances, but I just wanted to make that point that we are an accountable health organization, and it's very important that we keep the cost to be on the lower side. We do accept all the insurances.
That's great. So you do these ASCA docs for patients that are insured outside of your system, so who may have
Yes.
other insurance. Wonderful.
Yes.
And so with that, since you may be doing these for Medicaid, do you share these examples with policymakers to show the effectiveness? Are you able to have those conversations outside of the system?
Yes, we actually are. There was another paper by one of the same authors on the paper, Dr. I think he's one of the rheumatologists, and he actually published a paper in light of increasing the access. It was published in American Journal of Medical Care, and it showed that they are, because initially when we started the e-consult, it was in a very limited number of departments. I think it was just the rheumatology that started it because they had less number of rheumatologists, and there were a lot of questions coming in regards to specific labs, because the patients were on specific DMTs. So that actually improved, and they showed that the downstream revenue and the access has increased. So that's why our policymakers, the Geisinger, started increasing the Ask a Doc in other departments. And now it has been involving at least 12 different departments. And the plan is to increase it to more departments over time.
That's great to know. So when you increase this, I'm assuming you started with neurology because of the long wait times. There may be other reasons. Are you looking at specialties because of wait times? Is that how they're selected, or because they're high costs?
Yes.
Or what factors?
So it was the access to the patient care. Neurology have had a long wait time. As I mentioned, that the seizure patients were waiting at least 3 to 5 months before they were even seen. So these departments were selected based on the high cost of care, or if the access is not available anytime soon. But the plan for the future is to increase the access to other departments so that they are also involved. And it also helps the other specialists to ask specific questions. So if you have a question about a specific disease, you can always reach out to the person through Ask a Doc.
Thanks so much for clarifying. I welcome the group to share some questions for Dr. Malik. You're also welcome to take yourself off mute if you'd like to ask. Okay, while we're waiting.
Hi, I have a question. This is Sheena Reddy. I'm the program manager. I manage our eConsult program at Stanford. Thank you for such a wonderful presentation. I had a follow-up question to my earlier question about the 33-day reduction in the wait time. How we have also tried to calculate a similar metric, but it's really hard to do that at Stanford because there's so many parallel initiatives happening to reduce the wait time. And so we feel like we can't attribute it to this one program. Did that ever come up? Did that concern ever come up in your analysis?
That's actually a very good question. We actually are not as big as Stanford. So it's maybe it's easier for us to do this kind of analysis. And again, with the Geisinger Health Plan, we were able to look at different metrics as well. But again, I will check with my the data analyst, and I can maybe send you an email after I connect with Libby, and I can send you a reply as how we did get that data.
Okay, thanks, Dr. Malik.
Thanks, Dr. Malik.
Sure.
Any additional questions from our group?
Hi, not a question, but a comment. Thank you for doing the work and forging ahead for us to really right access member care. It's critical that we have all different forms of virtual strategy, whether that is remote patient monitoring integrated with virtual care. And so really appreciate all the work that you're doing.
Thank you so much.
Thanks, Misty. My last question for you, Dr. Malik, is around downstream revenue. Are you able to see or track of the patients that get e-consults? Are they coming back to you for procedures, or is that sort of what feeds into the downstream revenue calculation, or what are you looking at there?
So in terms of the downstream revenue, we are looking at patients who underwent diagnostic testing and whether that downstream testing led to any specific diagnosis. Again, I will give you an example of MS patient who presents with headache, gets an MRI. We see lesions, we start them on the treatment, and they that way we are preventing patients from having relapses. That is indirectly helping to reduce the cost to the healthcare system, but we are also preventing disability to the patient in the long term because they are getting treated earlier. So there are two different things in the downstream revenue, both from a patient perspective and from the healthcare perspective as well.
Thank you so much for your time, Dr. Malik. We've really enjoyed having you with this great example of cost savings and satisfaction. I love these examples, and we'll make sure that everyone has a copy of your presentation. We appreciate your time today.
Oh, thank you so much. You're very welcome. And I really enjoy listening to the talk and the comments. The questions were excellent. And I will try to get that information sent to you.
Great. And we will make sure we get the example Dr. Malik referred to with the additional paper on policy follow-ups from this research. So once again, thanks for your time.
Sure, you're welcome. Have a good day.
You too. Bye-bye.
Bye.
We talked a little bit about our progress in 2021 and what we're looking at for 2022. And with that, we have additional panelists that we're going to join in conversation in just a moment here. But briefly, I wanted to just thank everyone who contributed to our annual meeting. We have done this for many years now, since so many of you have been involved in this. And it's just been wonderful to see this group grow. We started out as a group, I think maybe we had 35 of us who gathered in Sacramento maybe 7 years ago. And since then we grew to having, nearly 200 people on the phone. Although we don't want to be on a webinar, we'd like to see you in person annually, just to be able to share some of the great progress that's been made. We hope to be able to do that next year. This year we were still in our webinar mode, which is okay considering the amount of the number of new faces we got to see. So if you weren't able to join us back on November 3rd, we have the link to our presentations, and we know it's 5 hours of presentation, so you're welcome to scroll to the exact moment of the presentation you'd like to see. Our monthly newsletter has those time stamps of where each presentation begins and ends, so you can take a look there. And thank you, Kira. Kira put the link to the video in the chat, so you can take a look there. This is our wonderful list of presenters. Some of you are on today. Thanks for your time and for sharing your wealth of knowledge with us all. It's great to have examples, not just from California, but all over the country, rural, urban, commercial, Medicaid, Medicare, all these examples to be able to share with you all. And huge thanks, of course, to our sponsors that have helped us throughout this year. And we look forward to moving into 2022. We appreciate California Healthcare Foundation for making this possible for all of us over the years too. And just a little bit about what we heard. If you would like to contribute and share your thoughts of what we want to see in 2022, we have a quick survey here. This has been sent out in your newsletter. If you already did it, you don't have to do it again. But thanks, Kira, for putting that into the chat. This is a survey on what we would like to see happen in 2022, what came out of our annual meeting in terms of priorities and what we'd like to do next. First of all, a lot of people want to hear from different stakeholder groups, what voices are we hearing from as part of our work group. And this is a quick little snapshot of those who attended or registered for our annual meeting. Obviously, a great number of providers. It's wonderful to see those representatives of provider organizations, obviously plans. The technology innovators that we have present are wonderful and key to making these interesting and dynamic presentations. We would love to see more policymaker representation, so we're working on that, and also patient or consumer representation. So we've heard that loud and clear, and we know that it's important for us to make e-consults more understandable to patients and consumers. Quick question for you, and this survey is still open, so we'd love to hear your feedback. This might change a little bit as we get more and more responses, but we asked, what do you wish we had more time to discuss? And this is not just our annual meeting, but throughout the year. We've spent a lot of time discussing research over the past year, and we know that there is a great interest in hearing about workflow. A lot of our presentations are about how e-consult's been incorporated into systems like Geisinger, and how we see the results of these programs. So it looks like we'd love to hear more about workflow. Some of the other quotes that came in are on how to spread, how to mainstream this, utilization, how to increase utilization by providers, and then more interest in research. I think we talk a lot about research, but we'll continue to be doing that. And it's always exciting to see that every month there's something published on e-consult and its effectiveness. So we'll continue sharing those examples in our monthly newsletters throughout 2022 with you all. So I think I touched upon this. Who is not represented? And we don't hear enough from consumers. So we'd like to involve consumer groups, actual patients, and community organizations. So not necessarily those who are for-profit organizations, but those who really represent patient needs. And next you can see that probably the next biggest group where we'd want to hear from is state agencies. So hearing the policy voice, hearing policymakers share what they need to hear from us. And I think we all have such a wealth of data now to be able to share. We want to know exactly what's going to be most important to those policymakers and agencies. And sorry, this is a little bit of fine print here. So you can see priorities that we mapped out in 2022, focusing on health disparities. We want to hear from plans that or programs that represent different business lines. So not just Medicaid, but commercial supported programs. Behavioral mental health is obviously a huge need, and we see more and more e-consult programs supporting those needs. Engaging primary care is, of course, such a big focus. We talked a little bit about primary care provider satisfaction today and what can encourage that. And, making sure that we can share examples of data and reporting that I'll show in just a minute here. Actually, that's my next slide. So some of you might be from the Central Valley out in California. This is the kind of dashboard and data reporting that we want to be able to share with you all, examples of how programs are able to show their impact. And this is the Central Valley of California. We work a lot with Anthem, with CalViva to be able to support counties, FQHCs, rural health centers, Indian health centers across Central California. And it's been great to see this program grow. And this is the kind of dashboarding that we'd love to be able to see from you all, examples of how e-consult impacts access to care. And last, just a reminder, if you're able to take a few minutes and share what you'd like to see in the coming year, the survey link is in your chat. What we're looking at doing in 2022, once again, engaging primary care providers, looking at health disparities, encouraging that kind of reporting, the data dashboarding that we just showed, encouraging reimbursement across business lines, and also not just focusing on Medicare or Medicaid, but also looking at Medicare and some of the challenges we've heard about helping with e-consult in Medicare settings. So thank you for sharing your feedback. And now we're going to spend a little bit of time discussing 2022. So we're so pleased to have Greg Buchert, who has been our advisor for a number of years now, joining us to share some of his thoughts looking toward 2022 and what our needs are. And also we're pleased to have Beth Malinowski, who's with California Primary Care Association, sharing thoughts. We spent a lot of time talking about reimbursement in California, how we can better support primary care providers. That was the origin of our State Bill 365. Now moving forward to 2022, we want to look at different ways we might address reimbursement or incentive needs for primary care providers. So Dr. Bucher and Beth, if you could take yourself or put yourself on video, we'd love to hear a little bit from you. And thanks for showing your video. Dr. Bucher, we'll start with you, just sharing some initial thoughts on what we might focus on in 22. Go ahead, Dr. Bucher. And Beth, can you join us? Can you take yourself off video too? I mean, place yourself on video, sorry.
Yep, yeah. Would you like me to go ahead, Libby?
Wonderful. Okay, Greg, I can't hear you yet, so we'll get Greg to make sure that he's off mute. But in the meantime, let's start with Beth. And sure. Beth, I have a sort of a general question for you that you might be able to help us out with as we are looking to 22. If you might share just what you see as opportunities outside of legislation. And we've looked at legislation. So outside of legislation, what opportunities might we have to support e-consult expansion at health centers? So California Primary Care Association supporting FQHCs. Maybe you can share your perspectives on that. Go ahead, Beth.
Sure, I'm happy to, and certainly want to appreciate having me join today. My colleague, Dr. Mike Whitty, our Chief Medical Officer, today is on as well. And so I'll just start by sharing in some ways. I heard earlier in the call the reference to the need to mainstream, right? And so just recognizing we have some incredible early adopters in the FQHC setting, and certainly we have seen increasing growth year after year of utilization of e-consult, but we do think there's a scaling that we still haven't seen yet. Certainly payment policy plays a part in that, but certainly just thinking about how we can use spaces like this as well as other educational opportunities to make sure that health center clinical teams are feeling more and more confident about how they can be kind of taking that leap and beginning to use e-consult. Maybe it starts with just one specialty and maybe it expands from there, but just recognizing that I do think we still have a fair amount of work we can be doing, and hopefully that's work CPCA can do in partnership with many of you on the line today to do that. And that education does need to happen side by side with thinking about both the operational side of e-consult. How do we make sure health centers have the operational confidence to build it in to their clinical teams and how they're supporting their clinicians in providing care to their patients. And then the other part of it, of course, it does come down in a lot of cases to the dollars and cents and making sure the financial incentives are there. I would say in addition, though, to the legislative efforts, there are a lot of important conversations playing out right now regarding the future payment for health centers, right? So for folks that are familiar with health centers, you may know that we have, by and large, a fee-for-service payment system where we have a lot of restrictions on when we can bill for care and who can be delivering those services. That has, especially before the pandemic, really limited the types of innovation that we saw linked to e-consult and other things as well. We are in a new place today, both because of what flexibilities have afforded us during this pandemic, and that I think giving health centers in some ways the permission just to think bigger about how they can be doing their work. And so at the same time that we're learning a lot about the flexibilities we have today and how that can transform our care for not only today, but for the future, we've also restarted conversations in the state regarding what we refer to now as payment modernization. And how do we move away from this fee-for-service model and to a model of an alternative payment system that allows for what we might define as an alternative touch. And we consider e-consult to be one of those alternative touches. And so with that, right now, through administrative engagement that we're having very intensely between CPCA, our partners at the public hospitals, our plan partners, as well as DHCS, we're engaging in very important conversations that will propel us forward to have an alternative payment methodology that is being implemented at some point in the next kind of 2 to 3 years. And of course, this will be an optional shift for our health centers. So there will be some period of time where we have both health centers operating under the fee-for-service or PPS system, while other health centers will choose to move forward into this APM. But as in this APM, we are going to see some really, I think, exciting change for how clinicians are doing their work. And I think this could really be a big space for e-consult to become a much bigger part of how our health centers, clinical teams are learning and being able to really do care in a different way and bring expertise to their patients. I will acknowledge that a lot of that work will require not only detailed conversations with the state, but also federal approval. I think we're really feeling confident now about our pathway forward. Legislative engagement might become part of that if needed, but for right now, we really do believe the state has a lot of the levers of control they need to make a lot of those important decisions to move forward federal approval. So I'd say that's kind of the other exciting area to watch would be just what we refer to as our alternative payment work or payment modernization. I was recognizing the time. I definitely want to give it over to the other speaker to add in as well.
Thank you, Beth. Go ahead, Greg. Can we hear? Let's make sure we
can you hear me now?
Yes, we can. Great.
Okay, great. Just a couple, since we just got 2 minutes left. A couple thoughts are regarding the consumers. I think it might be worth having a session next year that we just invite consumers and other stakeholders and advocacy groups to hear how we can deliver a message more effectively about selling this concept, because people come into PCP saying, I know you're a gatekeeper, I want a referral to go see some specialist. Well, maybe if we can change that dynamic so they're expecting to, have the PCP engage the specialist to get back to them, that PCP can manage the care, I think that would be helpful. And the other thing is with regard to discussing things with state agencies, I think we might need to take the show on the road. We spend a lot of time here talking, amongst ourselves, and we all believe this. But if we were to go to something like present at the National Academy of State Medicaid Directors at AHIP, which represents that vast line of business activity, and actually do a little bit more marketing proactively to people who aren't, already advocates and saying, I believe, I think that would be helpful. And then finally, with regard to health disparities, it's such a topical issue right now that if we can address tech equity and health equity and leverage that when an e-consult is absolutely a solution to help, one of many solutions that are needed. But let's take advantage of the fact that people are talking about that now and bring that into our discussions.
Thank you, Greg and Beth. It's been great to have you as ongoing supporters. We really appreciate California Primary Care Association's involvement in our group. And obviously out in California, FQHC Community Health Center involvement really is what keeps eConsult going. Those are probably our biggest users of eConsults that we see. And thank you, Greg, for your leadership and advice that you've given us over time in the past year. So thanks all. We look forward to seeing you in 2022. We will get our news out to you in terms of our ongoing meetings through our newsletters that share examples of publications like Dr. Malik's from today. We just want to continue sharing all the great work that's being done out there. So we hope you all enjoy a little bit of a break as we approach the new year. Thanks for your time today. Bye-bye.